It is my pleasure to stand in for Laura Bazzuto, who's on a much-needed vacation, I'm just quite certain, to introduce our speakers today. I have the pleasure of introducing Dr. Catherine Zhang and Dr. Elizabeth Sadowski. Dr. Sadowski is a professor in the departments of radiology and obstetrics and gynecology here at the University of Wisconsin in Madison, and she's been on faculty since July in 2002. She's the director of gynecologic imaging service, and her clinical and research focuses on gynecologic cancer imaging. She has a very impressive CV, being the founding member and current steering committee chair of the American College of Radiology ORADS committee, and serves or has served as the co-chair of the Society of Abdominal Radiology, Uterine and Ovarian Cancer Disease Focus Panel, the American College of Radiology Women's Imaging Appropriateness Criteria Panel, the ACR ORADS MRI Educational Committee Chair, and an abstract reviewer on the scientific committees for multiple national societies. She's helped lead the development of multiple guidelines, lexicons, and classification schemas for imaging gynecologic entities, including most recently the ACR ORADS MRI Risk Stratification System and the SAR ESUR Ovarian Cancer Reporting Lexicon. She has research interests in a multi-institutional research group collecting data on imaging adnexal lesions on ultrasound and MRI, and has published her works in the Journal of Radiology and JAMA. Dr. Catherine Zhang attended the University of Iowa Carver College of Medicine and earned her combined MD, MPH. She completed OBGYN residency at the University of Minnesota and then attended the University of Wisconsin-Madison for her gynecologic oncology fellowship. As a fellow, her plenary presentation at the 2022 Society of Gynecologic Oncology annual meeting was chosen to be one of the 50 abstracts included in the 2022 SGO Select Educational Package. She's been the recipient of the University of Wisconsin Department of Medicine's Hospice and Palliative Care Annual Humanism Award in Medicine, which is given to a non-palliative care member of the UW SMPH community who most embodies the attributes of compassion, collaboration, and person-centered care. She has stayed on after fellowship to join us as faculty, and I can say, as someone who has had the privilege of operating with her, she's an excellent surgeon and just a fun person to be around. So please join me in welcoming both Dr. Sadowski and Dr. Zhang.
Thank you for the kind introductions, and thank you everybody who is here in person as well as virtually. I'm excited to be here with Liz Sadowski, and we'll be going over a topic all of us are probably familiar with, the ovarian Adnexal reporting and data system, or also known as ORADS, Adnexal lesion characterization, and we'll be going over pearls and pitfalls. So the learning objectives of this presentation to start is to first define the goals and governing concepts of using ORADS, ultrasound as well as MRI. Trying to see if I can move this. There we go. We'll also discuss the ORADS lexicon and risk score, and then apply these concepts to real-life clinical vignettes. And neither of us have any financial disclosures to report. So we're going to start this talk by going over very briefly the 4 clinical scenarios that we will go back to at the end of this presentation. As you think about these scenarios, I'd like you to consider what additional imaging would you obtain in this situation, if any? Is the ORAD scoring appropriate to be using in this scenario? And how would you manage this patient based on both the imaging as well as clinical findings? So for the first case, this is a 39-year-old who presented to urgent care, with acute lower abdominal pain. She had a pelvic ultrasound that was read as an ORADS ultrasound 5 lesion. So again, what additional imaging, if any, would you obtain? And is ORAD scoring appropriate in this situation? And how would you manage this patient? For the second case, this is a 28-year-old G1P0 who had ultrasound, routine ultrasound at 14 weeks, was found to have an ORADS ultrasound 5 ovarian cyst. Third case is a 35-year-old who, while undergoing infertility workup, was incidentally found to have an ORADS ultrasound 5 right ovarian lesion. And then finally, this is a 25-year-old who presented with several-month history of abdominal discomfort and bloating, On workup, she was found to have an ORADS ultrasound 0 mass, and this is because it was incompletely imaged due to size. Okay, I'm going to turn it over to Liz.
All righty. Hi, everybody. So nice to see everybody. Thank you for inviting me. We're just going to go over some goals and governing concepts of ORADS before we dive into the cases. And so I think the first goal of ORADS is that everybody understands the imaging reports, which I think you guys being on the receiving end, you know, that's kind of a problem sometimes. And I have to admit, even when I read them, I don't know what some people are saying. But that's the goal of ORADS, is that we all understand each other. And part of it is using the same words all the time for the same entity, and also not using words that mean the same thing. And so something like complex is a word that we've tried to get rid of because complex could mean something benign, like this multilocular cyst with no solid tissue, which would be a benign thing, versus multilocular cyst with solid tissue, which then raises suspicion for cancer. So we've tried to get rid of those kind of words and then try to use the same words all the time. Second, we want everybody, every imager, to rate or score the lesions the same regardless of experience level. And that's super important because most of us don't practice in a highly academic, highly specialized setting. And so really to make an impact, we need to get everybody scoring lesions appropriately. And yes, we probably have a ways to go on this, but that is one of the goals. Lastly, using ORADS allows for more patients to be treated appropriately, meaning women who have a high risk of cancer go to gyn-onc immediately or very quickly, and those that don't have a high risk of cancer can be treated more conservatively. There are some governing concepts to remember when you are applying ORADS or when you see an ORADS score in a report. First, that all the PPVs or the risk of malignancy percentages you see in those charts, they apply to an average risk patient. And so if you have a high risk patient, the PPV is going to be a little different. It may be a little higher, but we don't have any data to say that. I'm just thinking that's probably going to be the case when that data comes out. Also, you have to make sure that the exam was appropriately done. And if there's missing ultrasound images or missing MR sequences, you're going to get the wrong diagnosis potentially, and you're not going to be reaching those PPVs or the risk of malignancy percentages you see in the chart. And if you want to think about this differently, it's kind of like asking a pathologist to make a diagnosis just on H&E and not allowing them to do like their other stains so they can be more specific. If you don't have the diffusion weighted images, or you don't have the curve, the perfusion part of it, you can't really make the best diagnosis on MR. And so that's kind of a way to think about that. Also, ORADS shouldn't be used in the non-acute. It should only be used in the non-acute setting for the most part. If you are seeing it in the acute setting, you should use it with caution. Really, there shouldn't be a score given in the acute setting, and you should treat based on the clinical picture. And why is that? Because things like ruptured cysts, PID, torsion, they can look like cancer, and cancer can look like these other entities. So unless it's super obvious that there's this big ovarian mass or there's peritoneal disease everywhere, I think in the acute setting, you have to be a little cautious when you see an isolated ovarian lesion, and ORAD shouldn't be given as a score. I'm not going to go into too many details because I want to get to the clinical cases, but I did want to refer you to the ACR website. So if you Google ACR ORADS, you can get to this website. You can click on these tiles. There is the tables, the lexicon, there's calculators. So if you need to calculate, like you're seeing something on ultrasound and you want to get a score, so you can find all that there. I do want to briefly go over the lexicon and score because I want to make sure we're all on the same page. So the terms we use in MR and ultrasound are very similar. If we see something and it's a corpus luteum or a follicle, we're just going to call it a physiologic finding. If we don't see something physiologic and we see an actual thing in the ovary, we're going to call it a lesion, and it's going to be unilocular, multilocular, or solid. If there's fluid, we have some fluid descriptors for the fluid. It's going to be simple. If you see on ultrasound, it's anechoic, meaning black. Whoops. And then no blood flow inside. And behind it, there is brightness, or what we call through transmission. It's hemorrhagic if there are low-level echoes with some what look like internal septations, or we call it cobwebbing or reticulation. If there's a flat or concave, like retractile clot. If there's through transmission, so through transmission, this is a good example of it. So it's kind of, this is the echogenicity on this side of the cyst, this is the echogenicity on this side, and behind the cyst, it gets bright. Then we know this is fluid, and this is not a solid lesion. And then there's no blood flow in it, which also tells us it's not a solid lesion. We have endometriotic fluid, so very low level echoes. They're a little on the bright side, but they're very smooth, versus proteinaceous fluid, which there's lots of little reflectors in there. And so it's a little more heterogeneous. And then we know it's proteinaceous fluid like mucin or pus. We have solid tissue descriptors that kind of raise our suspicion for cancer, like nodules, irregular septations, papillary projections, and solid mass. And we also have solid appearing things that we're not worried about. So like blood clot, concave margins, little reticulation or cobwebbing, no blood flow, or fat. Fat is very hyperchoic, and sometimes it has this very dense shadowing behind it, attenuating the sound beam. And we call this tip of the iceberg. If you've ever heard that, this is a nice tip of the iceberg sign, and that tells us it's a dermoid. Risk score. Quickly, 1 to 5. As you get from 1 to 5, the risk score increases to greater than 50%. For the most part, in ORADS 2, you've got your simple cyst, your endometrioma, your hemorrhagic cyst, and your dermoid. If they're greater than 10 centimeters, you're going to throw it into ORADS 3. Multilocular lesions go into 3, and very smooth lesions that look fibrous, so they have some shadowing to them. Everything else goes into 4 and 5. So all those lesions that have irregular septations or nodules or flow in soft tissue, they go into 4 and 5. MR is very similar. We have a 1 to 5. The higher you go, the higher the risk score. And if you're in a 5 category, the risk of cancer is greater than 90%. Similar to ultrasound, all your benign classic lesions, simple cyst, endometrioma, hemorrhagic cyst, all those are in 2. We also throw fibromas on MR into 2 because on MR, we're able to tell something is fibrous by what it looks like on T2 and DWI and how it enhances. So we can be very specific, which is not something you can do on ultrasound, and that's why it's in 3. In 3, we have the multilocular lesions on MR and things that don't enhance very much. And everything else goes into 4 and 5. How do we do diagnostically with ORADS? Well, ultrasound ORADS, very sensitive. Specificity is kind of a range, because if you're looking at a classic benign lesion like a simple cyst or endometrioma, our specificity is very high. But if you're looking at a lesion that has some solid tissue to it, plus or minus blood flow, the specificity is a little on the lower side, because benign and malignant lesions can both have that appearance on ultrasound. MR is more sensitive and more specific. It's more specific because we're able to tell with our different sequences, kind of like a pathologist with their stains, what is that tissue? And then we can tell you it's benign or it's malignant, or there is an I don't know category, because there is a little bit of overlap on MR as well. All right, let's go to the clinical vignettes.
Thanks, Liz. So the rest of this time for this presentation, we really wanted to go over the 4 clinical vignettes that I had presented earlier in this talk. And these are really clinical scenarios that were based on cases that I had seen in this last year. And I really feel like kind of highlight some of the potential pitfalls as well as clinical pearls to take away in regards to usage of ORADS. So again, this is a 39-year-old who presented, oh, excuse me, let's go back.
Oh, that's a spoiler.
Let's see, is there a way to go back without going through all the
I
slides?
think maybe
Exit out of it.
Maybe exit out of it.
Yeah. No, I think it's up here.
Oh, is it? Oh, yeah, you're right.
One moment here. Okay, let's start
And then
again. Let me just start this and then. Okay. Share. Here. I think I did it.
All right.
Okay. It's not sharing. Okay. No, it's okay.
Wish I could sing, but I can't.
Oh, there we go. Yeah, I think if I did that. Okay, great.
Thank you.
All right, thank you. All right, so this is a 39-year-old who presented to urgent care with acute lower abdominal pain. A pelvic ultrasound was obtained, which was read as a ORADS ultrasound 5 lesion. She was subsequently referred to gynecologic oncology. I saw her in clinic about 1 to 2 weeks after her initial presentation, at which time her pain had improved. She at that time was uncertain if she was completed with childbearing. And so we did discuss fertility sparing surgery depending on intraoperative findings and if that would be appropriate. I consented her for a laparoscopy, unilateral self-pingu oophorectomy, possible staging. But prior to surgery, I did have her get a pelvic MRI in the non-acute setting. So Liz is going to go over her imaging.
Okay, so I think first, I don't know if I agree with that outside read because it's an acute setting. And so I personally wouldn't give a score and I don't think you should. I think instead you should use descriptors and just say this is a cystic lesion with some nodularity along the septation, with a little bit of blood flow. Depending on the clinical scenario, it could be, an abscess, a TOA, or a torus tube, or a ruptured cyst, or it could be an adnexal lesion. So I'm not really sure what this is. But I'm glad you got an MR. So let's look at the MR. So we're going to do this together. So these are T2 weighted images, and T2 is a sequence we use because we can see things very nicely on it. The tissue contrast is very nice without contrast, and you kind of see some bowel here in the picture. And then you see this little bright little thing right here. That's a little cyst along the left pelvic sidewall. And then this is ovarian tissue here. This black line is around the ovary, and this is the stroma. And I don't see that lesion that we saw on CT. No, was it a CT? No, it was an ultrasound, sorry, on the ultrasound. She probably got a CT too, though, because she was in the ER. Yeah. But anyways, I think we just saw that on ultrasound. So we do see the fallopian tube here too in the mesosalpinx. So like this is the fimbriated end and that looks fine too. And then this blob in the middle is the uterus. And we see the myometrium, the junctional zone, the endometrium, the cervix down here. That all looks fine. And then in the right adnex, I don't see anything either except for this ovary, which is sort of on the gray side with this black line around it, which is fine. No follicles there. And the mesosalpinx here we can see. So I would give this a normal ovary ORADS 1 on MR.
Great. So in summary, this is a 39-year-old who had initial what was read as ORADS ultrasound 5 left ovarian lesion. She did have a subsequent pelvic MRI that demonstrated normal ovaries. And so, with that finding, I did go ahead and cancel surgery, given that no intervention was indicated. She had just moved to the area, and so she had not yet established care with gynecology. And so I put in a referral for her to do that. Takeaways from this case, really for me was in the acute setting. And as we mentioned earlier in this presentation, ORAD scoring really is not applicable due to many of the reasons that Liz said, as benign lesions can be overcalled in the setting of inflammation. And so ruptured cyst, torsion, PID, abscess can all look like cancer and vice versa. And so the treatment should really be based on the clinical picture. And if the patient is stable, obtaining a follow-up imaging in the non-urgent setting would really help to elucidate what's going on. I want to make sure that we open up this time to answer some questions. This is meant to be kind of an interactive portion. And so does anybody have questions about this case? Yeah. Ellen, yeah.
A lot of other people have their questions too. So my question is, what do you think she did have? What do you think she did have in the acute setting?
And could another pathway have been to do a follow-up ultrasound? Or when do you decide to do a follow-up ultrasound versus an MRI? I mean, obviously MRI was nice. I mean, we're using more and more MRIs, and I love MRIs. And I so appreciate Dr. Liz Sadowski. So I think it's really important for us to figure out some of those things.
I think you could definitely consider ultrasound in certain settings. I think in this case, like, there was no free fluid, and so like ruptured cyst, like I would consider follow-up ultrasound if I thought it was a ruptured cyst, or she had like discharge and you thought it was, like, there was nothing in her, it was just pain. So we were just kind of like, oh, there's no fluid, there's no vaginal discharge. It was just really like, yeah, that looks pretty suspicious. But
What do you think she did have?
probably a ruptured cyst, or maybe she had like a dilated tube from like a partial torsion. I don't know. I don't know what she had. I really don't know what she had. It was a very non-specific finding, but I think that the nodularity kind of worried us a little bit. And even though I wouldn't give it a 5, I would be like, yeah, it's not, if you guys don't think it's anything clinically, then what am I going to say? It's on imaging, it is a little suspicious. So I think that's why they headed to MR.
Yeah, no, MR makes sense. What are the cost differentials?
The cost differential, so an ultrasound is somewhere like, I think 1,500 or so, like that, like 1,000 to 1,500, depending on if you do certain things like Doppler and how you do the Doppler. And then MR is in the 4,000 range, so it's much more expensive. So I think clinically, if you find something and you're like, oh, it's probably a ruptured cyst or it's probably PID, I'm not even sure you need follow-up. I think in this case, there was nothing leading to a clinical diagnosis. And
Oh,
so,
we need a follow-up with abnormal imaging and clinical findings, like,
well, so I think on ultrasound, if we see something that correlates with your clinical picture, we're just going to say it. So like, say that that patient had vaginal discharge rather than nothing but pain, we would have said, oh, this could be a TOA. So we'll give you a diagnosis and then you don't have to like follow her up. In that case, all she had was pain. She had no free fluid on clinically. And I don't know if Guy saw her or not. I really don't. But I remember that looking at that case, there wasn't like a diagnosis that they gave us that they could help us with. They said, oh, she just has pain. So we have this incidental lesion with pain.
I'll open it up to other people.
Hi, it's Jay. I'm remote. Can you hear me?
Yeah.
I'm curious. Did you order tumor markers at the same time as the MRI, or did you order the MRI first to see what you would see with?
Yeah, she did have tumor markers, which were normal
Okay,
prior to
thank
the
you.
MRI. Yeah.
Would you wait normally for the imaging before you ordered those tumor markers?
Would I wait for you being the pelvic MRI or?
Yeah. Uh-huh.
Not necessarily. I think because she had the ultrasound that was at ORADS 5 and concerning for malignancy. I can't recall if the tumor markers had been ordered prior to her being seen by me or if I had ordered it. But I would not have waited for a pelvic MRI to get those.
Okay, thanks.
I'm just going to say something real quick.
Yeah.
So this ultrasound was done here at UW.
Yeah.
Yes.
Okay. Yeah, I mean, I think that's part of the problem we face is that, not everybody knows, to do not do ORADS in an acute setting, all those things. The other problem is getting, most of our ultrasounds come from somewhere else, right? And a lot of our patients come from somewhere else. And the MRIs that you get, a lot of patients are like, well, can I just get the MRI done, in Northern Illinois? And in my experience, the answer is no, they can't because, the reading isn't as good or the technique isn't as good. And so we're sort of limited in what we can tell them. And then my other comment just quickly is, had that not been an ORADS 5 lesion on ultrasound, I would not have gotten tumor markers in a 39-year-old patient with
Right,
pain,
yes.
because I think you're going to set yourself up for having, false positive a lot of times when you
Yeah,
do
I
that.
think it was because it was ORADS 5 that I did. But
right.
yeah.
And then you're kind of stuck. You kind of have to do it. But
Yeah, I think this was a difficult case, which is why we presented it, because she really, I mean, it looks dangerous on ultrasound. And we didn't have a diagnosis for her other than she had this pain. I did want to make a comment about getting outside imaging. And so the thing about outside imaging is that, yes, eventually everybody will catch up, but that's going to take time. And I say eventually only because this is a ACR initiative and because just like BIRADS, I just don't think it's going to go away, but that may take a decade. In the meantime, you can always ask us for an overread, an outside overread, or opinion, and maybe we can't give you an ORAD score, but we can certainly say, you don't need an ORAD score all the time. You just need us to say, oh yeah, that's definitely benign. That's just a simple cyst, or oh, I don't really know what that is. And then you can take that into account when you're treating the patient. But yeah, so it's not a perfect system at the moment, but I mean, it just kind of started. So it's going to take a little time for everybody to get on board.
Ordering an MRI, I would actually have the patient come here if they can come here.
If they can come.
Yeah, I mean, there are a lot of patients from the Northern Illinois region that have a hard time with transportation. And if you have to have it down there, that's okay. But where you can have patients come here, because I do think, you know, the reads are a bit better and more sensitive.
Hi, I have a question.
Oh.
Just kind of like reflecting on this case, like if I saw this patient in the emergency room, a 39-year-old who's coming in with a lot of abdominal pain and an adnexal lesion and might desire future fertility, something we would consider as ovarian torsion, maybe even like intermittently. And if the ultrasound findings didn't show this ORADS 5 lesion, this is someone that might have gone to the OR for like detorsing or what have you. And I'm just wondering, in your experience, do you feel like sometimes these like ORADS readings taken in the acute setting miss some kind of intervention that the patient could have had when they presented with the initial symptoms?
I think in this particular case, there wasn't a concern for torsion just because they did do Dopplers and there was flow to that ovary. I would hope that, in the setting of concern for torsion, first off, the ORAD score shouldn't have been there anyway. But even with the ORAD score, that would still prompt bringing the patient into the OR due to concern for torsion. Does that answer your question?
Yeah, like
Yeah.
there was not that concern at the time.
Yeah.
Thanks.
I did want to say one thing though. Sometimes there is flow in the ovary and there's still torsion, right? Because so I think that honestly, I think we kind of miss partial torsion or early torsion or torsion detorsion sometimes. I mean, it's just because it goes away. And so I mean, I've had several cases where like, oh, it's torts, and they come over here for the operation because I think that's what happens. And then I get the read and there's no torsion. So it's a phenomenon that's sometimes temporary. And so you have to keep that in mind too. But I think all of these patients, like as clinically are followed, if they continue to have pain. If the pain goes away, that's a good thing. And then we just don't know what happened. Like in this case, we really don't know what happened. So.
Long before we hit that.
Yeah.
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 And behind the index of
Right.
Mhm.
Right. I mean, even if there's an ovarian lesion, that's true. Pretty much, yeah. Pretty much, yeah.
Yeah, I think that's where you have to use your clinical judgment. Yeah. Yeah.
Correct.
Would you mind repeating the questions for the people who are remote?
Oh, the question was, if I saw this person in the ER, how would I know torsion wasn't happening? And did the ORAD score prevent that person from taking the patient to the OR? Pretty much. That was the question, right?
Yeah.
Okay.
Okay.
All right, we're gonna move on.
Yes, we're gonna move on to the next. Oh,
No,
yeah,
you're
go
gonna
ahead.
move on, but the answer to the question is,
Oh, yeah.
an ORAD score shouldn't prevent you from going to the OR on a patient you have a high index of suspicion for torsion.
And I think that's kind of really the point is, particularly in the acute setting, we really should be using your clinical judgment and not an ORAD score to decide how best to manage the patient. Okay, the second case is a 28-year-old G1P0 who on a routine ultrasound at 14 weeks is found to have an ORADS ultrasound 5 ovarian cyst. She was referred to gynecologic oncology. In the interim, she did get a pelvic MRI. Lindsay's going to go over the imaging.
All right, on this case, I do agree with the read here. This is ORADS 5 mainly because of the number of papillations. And I know we don't have Doppler here, but in ORADS, the number really matters, at least for papillary projections. So this would be an ORADS ultrasound 5. So on MR, we're going to start with the T2, and then we're going to have some contrast images. And so here is the uterus here, and the baby is in the uterus there. And then off to the side here, we have this ovary, and this ovary has a lot of follicles compared to the last ovary we saw. And so, yeah, ovaries look variable, depends on hormonal status and if, how old the patient is, things like that. But obviously, in a pregnant patient, lots of hormones, so little follicles are there. The stroma is the gray part. And then here's that cyst we saw on ultrasound. And are there papillary projections here? Or is this on T2? Sometimes when fluid moves, it can cause artifacts. So I'm kind of like, well, I think it's mostly simple, but I'm not really sure at the top there. So I'm actually glad we were able to give furomoxetol here, which is safe in pregnancy, as you know. And so again, this is the uterus, and off to the side is this cyst. And if it were enhancing, it'd be as bright as some of these structures that are enhancing, and it is not. There's absolutely nothing enhancing, and this is super reassuring to me that there's no enhancement. In fact, when there's no enhancement, there's 0% chance of cancer. That is like something that we have seen over and over again, thousands and thousands of cases of non-enhancing lesions. Not a single one has been cancer. So I feel super confident calling this a simple cyst and an ORADS 2.
Great. So summarize 28-year-old G1P0, 14 weeks, initially found to have an ORADS ultrasound 5 left ovarian cyst. She did get a pelvic MRI with ferumoxetol as a contrast agent that was consistent with a simple para-ovarian cyst. So really no intervention was indicated, and we had recommended continuing routine OB care. So this case was really helpful for me to see. I think I've seen 2 now where obtaining a subsequent pelvic MRI with the use of ferumoxetol. So as you guys know, gadolinium-based contrast agents are contraindicated in pregnancy due to some of it being transferred into the amniotic fluid and theoretical risk of terogenic effects. And so ferumoxetol binds to hemoglobin and iron and is safe to use as a contrast agent in pregnancy. And so it is really useful to identify if there's enhancing solid tissue that would be concerning for malignancy. And so as was done in this case, it helped to really exclude that concern. Questions about this case at all? Okay, great. The third case is a 35-year-old who during infertility workup was incidentally found to have what was read as an ultrasound ORADS 5 right ovarian lesion. You will sense a theme here. We got a subsequent pelvic MRI. And so Liz will go over all of that.
All right, so part of this is like, if you see this on ultrasound and you know the patient is done, with her children, she doesn't want any more children, or she's not young, she's not premenopausal, I'm not really sure you need anything else. And this is definitely an ORADS 5 lesion because there is solid tissue, it's got an irregular border, and there is flow. So that would meet criteria for ORADS 5 in ultrasound. So this would be a case of like, okay, you don't need anything else, unless you're trying to figure out something else. Like, well, do I want to know if this is maybe a benign tumor? Because only 50% of ORADS 5 lesions are going to be cancer. The rest are going to be some benign entity on ultrasound. And so you have to keep that in mind. I'm taking this person to the OR. Am I okay with that? In this case, because she was undergoing infertility workup, folks did want to know, can we tell what kind of lesion this is on MR? So in addition to giving a score, MR can also sometimes give you a subtype. And again, this is kind of vary where you get the MR. And so if you send the patient to an academic center, you're probably going to get a subtype or may get a subtype. So that is something to keep in mind. So this is a sagittal image. It's a T2. This is the sacrum here, and the pubic symphysis is here. And in the center of the pelvis, there is this area here, and this is the ovary, and then some follicles. And then around the ovary is this kind of white or high intensity material. And there's these little branching structures within that. On the axial, this is the ovary here, and there is this white stuff and kind of like snowflakes or branching. These are what we call papillary projections. So on MR, papillary projections have these little dark branching structures, and then all the glandular tissue is very bright. I also have a diffusion weighted image here for you. It's sort of like PET, where you're like, what am I looking at? But there's bright signal on there, and then you're like, oh, okay, that's not normal. And so it just draws your eye to the abnormality. And so yes, those papillary projections are abnormal. There is this little dark area in the ovary here that's dark on the DWI. If something is very dark on T2 and dark on diffusion, we think it's fibrous, we think it's benign. So part of this lesion, I'm not really worried about the dark part, but the papillary projections are not so nice. So then I'm going to look at the perfusion. And so this is a perfusion curve, and this kind of purple or blue curve is the uterus. And we kind of match that to what the material or soft tissue in the lesion is doing, and we see that there's very little enhancement. So this is a low risk curve. So I'm very confident to give this an ORADS 3, but I don't like the papillary projections. I think, this can still be a borderline tumor. So I'm going to say that this could be a borderline tumor.
All right, so this was a 35-year-old who had initial ultrasound that showed an ORADS ultrasound 5 right ovarian mass. She did have a slightly elevated CA-125 of 105, and then had a subsequent pelvic MRI that was just reviewed showing ORADS 3 right ovarian mass. So she was counseled on management options, and given the elevated CA-125 and concern for possible borderline tumor, she did elect to undergo surgery. She had a laparoscopic right oophorectomy, and her final pathology came back as a benign endometrioid papillary cystadenofibroma. So being benign, the recommendation was to continue care with REI, as well as her general gynecologist. So I think, thinking about takeaways from this case, really for premenopausal patients who are desiring fertility preservation, I think our threshold to bring them to the OR should be pretty high. And so understanding that on ultrasound, benign lesions can sometimes look solid as well as concerning for malignancy, getting a follow-up pelvic MRI can be helpful to decrease concern as well as potentially help with subtyping. Any comments, questions about that case?
In retrospect, do you wish you had done a cystectomy of some kind? Could you have done that and for an ORADS 3 in a fertility patient?
Yep, that is always something to consider. This is not a case that I had done, so I don't know exactly intraoperatively how it looked, and if a cystectomy was possible, but I do think if it was a lesion where there was a significant amount of normal ovarian tissue, that's something that you could consider.
So it wasn't, you didn't do the surgery?
I didn't do the surgery,
Oh, okay.
no, not this case,
Okay.
yeah.
Because I mean, I just want, I mean, I love ORADs, and if
Yeah.
and I love MRIs,
Yes.
and even though they're costly, I just want everybody to know, because if you can save someone from surgery, that's like saving cost. But I just wonder if you've got a young person in that 3 range, I mean, are we getting better and better? Could we do something we haven't necessarily done before and try and be more conservative in that fertility preservation? I can also see Bhagavath right now, so so I can't help myself there. And the other question I have for you, Liz, is in the ORADS world, are we just supposed to use age inside our own brain, about you know, the risk, because, I mean, we all know that the risk of malignancy increases with age. And so, you know, like the ORAD score in someone 35 versus the ORAD score in a patient in the perimenopause or postmenopause. Are we just like supposed to clinically just use that in our brain?
Yeah, it's very interesting that we haven't included age. And the reason we haven't included age is because most of the studies that have been done recently, age hasn't been a clinical factor when there's certain imaging criteria present. So like in an ORADS 5 lesion, I'm not sure age is going to help you. But we have those on ultrasound.
Yeah, and I don't mean 5.
Ultrasound.
I don't mean the 5.
Yeah, but the 3 and 4 need a lot of work. And I don't think we have the data on those. We haven't been doing studies on ORADS lesions and age, other than the meta-analyses, which means that when you do a meta-analysis, you're throwing everything in there. And when you pick 4 as the cutoff, so far age has not made a difference. I don't believe that. I do think if you take the 3s and 4s by themselves, age is probably going to make a difference. And so, yeah, clinically, I think it would be a good idea to use it for ultrasound. MR is a different story. I think if you have certain criteria, so MRs, both of them are going to go through evolution, but MR, like if you see papillary projections, there is no way that is not a tumor. So even in somebody who is young, you may want to consider, you know, yeah, it's a lesion. It's a lesion. Right. So I think, yeah, but we're not there yet, but yeah, it's a neoplastic, yeah. But if it has a low risk curve, the chances of cancer are only 5%. That's solid. In 3 can come out.
Well, neoplastic lesions need attention.
Yeah.
And like every
But
gynecologist needs to know that.
right. But who's going to take care of them? That's what you're saying.
No, that's not what I'm saying. I'm saying we got to figure out what's going on with this lady
Yeah.
and get her the right care.
Yeah. And I think age, right now, age has to play a role for on the ultrasound side. On the MR side, I'm not sure age is as helpful. That's my answer. And then there's a question in the back. So the question was in the same vein, is ORADS validated in children? It is not. And but there is a group out of Cleveland that's doing kind of a multi-center study on children.
I'm so glad that you said that. It sounds so much better coming from you, Ellen, than from me. I have been on this soapbox before, as you know, that we should be thinking about saving ovaries. You know, not just 35, because many of my patients are in their 40s. This is a sad reality of today's fertility care. They are more and more towards the late 30s and early 40s. So we should always be thinking about saving ovaries. And in this particular case, as Liz presented, there was very low suspicion of cancer that should have given enough impetus to try and save that ovary rather than taking it all out. Thank you.
Okay.
So I think one thing is like, I can't remember this case, but maybe like when you guys sent the thing to pathology, maybe they said they couldn't figure out if it was benign or malignant. Maybe that,
Yeah,
oh, sorry, frozen section. Words matter. Frozen section.
All right, we just have one more case here. We'll go over this one pretty quickly. It's rather straightforward. A 25-year-old who had multiple months of abdominal discomfort and bloating. She on workup was found to have an ORADS ultrasound 0 mass, 0 as it was incomplete image due to size. Liz is going to go over the ultrasound findings. She also got a pelvic MRI that she'll go over.
Okay, so this is the ultrasound here, and sure enough, we have lots of artifacts, reverb artifact that's kind of obscuring parts of the wall. So I'm not really seeing the entire lesion. I don't know, it sort of looks like a simple cyst. She's very young. I'm not terribly concerned. Unfortunately, on MR, when we took her to MR, she had this kind of branching thing that I've been showing you as a papillary projection. And she had a little papillation or irregularity posteriorly. And if you look at I don't have a curve on this one because this is an older case, but if you look at the uterus, So you can use the curves, or you can just look at the uterus and decide, is it enhancing less or more than the uterus? So it's enhancing less than the uterus. So that would be a 4. But this papillary projection, I'm going to say, is definitely worrisome for a borderline tumor, benign or borderline tumor, or even low grade in this case.
So given these findings of the ORADS MRI for left ovarian mass, she underwent a left self-pivot oophorectomy omentectomy, and final pathology did return as a borderline serous tumor, and she is currently undergoing surveillance for that. And so really with this case, it's just to show that particularly if a mass is large, it is incompletely imaged, even if it may look simple, benign on ultrasound, a follow-up MRI is indicated to just exclude any areas that could be concerning for malignancy.
Any questions on that case? Like, it was a big lesion, right? So big lesions are hard. The question is, if for a big lesion like that, should you order an MRI of the abdomen and pelvis? No, you can just order a pelvis. We cover the entire mass. And even if it goes up into the abdomen, we will cover the entire mass. And that's pretty true outside too, has been my experience.
Yeah, thanks for that. One question I have, we've been talking about ultrasound and then MRI. And as I said, I love MRI. I'm just wondering for the audience, in the Adnexal world, is it ultrasound then MRI? And when, if ever, would it be ultrasound, CT, and MRI, unless they just went to the ER, as you said? Like, you know, is there a time where you'd want to go for an adnexal mass, ultrasound to CT versus ultrasound to MRI?
I think that I don't think for characterization, CT, you can't really do characterization on CT. So if you're thinking characterization of the mass, CT is not indicated ever. I think if you think it's cancer and you're not going to get the MR because you're really sure it's cancer, then CT would be appropriate for the staging. So we mainly don't use CT, and there is some data out there. There's more data coming that CT is just not very good at telling you if it's cancer or not cancer. So in the setting of cancer, no cancer, I would not get a CT before.
Right. I just wanted to hear you say ultrasound to MRI, ultrasound to MRI for adnexal
And
masses,
that's the
ultrasound to
case. I mean,
MRI.
Other cases are ultrasound to MR, but we just wanted to highlight some
Right.
problem solving. This is probably most cases, and that's actually our final thoughts, is that most cases
Ultrasound to MRI.
you're just ultrasound. You're just ultrasound. I think ultrasound you can stop most of the time, even though none of our cases said that.
Yeah.
But that was on purpose so we could show you the MR. So, was there any other?
That was it.
Okay.
Oh, there's
Well, there's one in the chat. How do we get to the chat?
I can just read it too.
Oh yeah,
Oh,
read
if
it.
you read it,
Yeah,
that
if you read
would
it, that'd be great.
Can ORADS US classification be used for US ultrasound done in the office, lower resolution images, or reserved only for those done in radiology?
You can use it in the office. I don't know what you mean by low res, but as long as you have a transvaginal exam, where you're seeing the entire lesion and you use Doppler to make sure there isn't any blood flow, you can use ORADS ultrasound.
You know, your comment about getting, a decade from now, everybody will be well trained in pelvic MRI and ORADS. What kind of penetration is there like now? I mean, are community practices using it? Are all academic practices using it? Like, where are we with ORADS nationally?
That's a good question, and I actually wanted Catherine to send out a survey
Yeah.
to ACOG and SGO and figure that out. I have no idea. No, I feel like this is just my feeling. My feeling is most academic institutions have adopted ORADS in some fashion. And we are, you know, at least the people I'm working with, which is at least 10 institutions, have implemented the proper MRI protocol. I think everybody else is in various phases. So I think we have a ways to go. That's why I said a decade. Oh, and then there is, since most previous data were from CT, can we use that data to help improve the ultrasound classification? I don't think there is data from CT. Most data is, so there's ultrasound. There is no studies using CT to characterize adnexal lesions. All previous data that ORADS is based on is, so the ultrasound, ORADS is based on IOTA data out of Europe, and that's an ultrasound study. And then the MR data is based on the URAD study, also out of Europe. CT, so the thing about ORADS is the goal is to get early ovarian cancer, right? And isolated lesions. Once it's meted out, like you don't need ultrasound or MR to tell you it's cancer, right? So the goal is to get early ovarian cancer. Early ovarian cancer looks the same as a normal ovary many times on CT. So it's very hard on CT to tell you that there is an early lesion. And so CT is not, it doesn't have the capability because it's based on density, and the density of cancer and the density of the ovary is the same. So how are you ever going to tell there's a different density if they're the same density? That's just physics, which I'm not a physicist, but we had to like do a little bit of that.
Great, thank you. That's very helpful. I guess then would there be enough data from the past year where since you've implemented this procedure here to sort of learn from the existing ultrasound data?
So we are collecting data at multiple institutions, both for ultrasound and MR, to continue to try and better tweak both systems. So yes.
Cool, that's great.
All right. So
Thanks.
I think we have 5 minutes. So is there a role for using, final thoughts are very quick.
Yes.
Is there a role for using other scoring systems such as IOTA? So IOTA and ORADS are actually, so ORADS is IOTA, but it also includes a little bit of SRU information in it. So you can use IOTA, but they're kind of the same system. So all the things in ORADS are from IOTA. And then on top of it, there are descriptors that were used in the SRU criteria that came out in 2010. And it kind of takes both the SRU and the IOTA and puts it together and then gives management guidelines. So yeah, I mean, you could use IOTA if you want.
Is IOTA still available? Because I know the FDA did something with their algorithm that was available online for free, and they had to take it down because they viewed that as a medical test or a device, and they had to apply for a separate patent. So IOTA was kind of a helpful tool online for those who have used it and could give you, albeit not perfect, statistics on the percentage of time that mass was going to be borderline malignant or benign. And I thought it was helpful in some cases, but I don't think you can find it any longer. I think they had to work on a patent, but.
Yeah, I know what you're talking about, and if you go to the IOTA website, yeah, I don't know if that's existing anymore, but that might be partly because IOTA and ORADS they're the same people. Yeah. All right. Okay, so final thoughts. Most of the time, ultrasound is going to be enough, particularly when you see a benign lesion like a simple cyst, a hemorrhagic cyst, endometrioma, or dermoid. You're kind of done. Also, if it's obviously cancer, so like a big lesion that has a lot of soft tissue, or even a smaller lesion that has a lot of soft tissue and blood flow, or peritoneal disease, you're done. You may also not want to move on to MR in these cases, but we went over some cases where they are helpful. And so sometimes when you have a ORAD 0, if it's a really big lesion, you may just be like, well, I'm going to take it out anyways. And that's fine. But if you want to know a little more information about it so you can better plan for the surgery, then an MR could help you figure out, is it benign? So that we showed a case in a 25-year-old where it really did look like a simple cyst, but had that gone to a gynecologist, I think then she would have had to see a gynonc afterwards. And so it's nice to get it right the first time and send her where she needs to be. And after MR, we could do that. And then if you have a 3, 4, or 5, and there's some reason that you need more specificity for cancer, so you want to be more sure it's cancer, or you want to exclude cancer because a lot of the lesions on ultrasound turn out to be benign, you can get an MR. And then if it's an MR 2 or 3, you know it's benign. And if it's a 4 or 5, the risk of cancer at a 4 is 50%, and at a 5, it's 90%. So that'll just help you in your planning. All right, thank you very much for your attention.